So now we move to the second speaker, Dr. Shourouk Gilawais. Dr. Shourouk, she is a clinical pharmacist at King Abdulaziz University. Dr. Shourouk, she is a clinical pharmacist at King Abdulaziz University in Riyadh. Dr. Shourouk completed her residency program at Masjid Hospital in Colombia. Dr. Shourouk, her research is oriented toward antimicrobial stewardship, antimicrobial multi-drug resistant organisms, pharmacoepidemiology, and medical science. Dr. Shourouk, she will present a very interesting topic about calcium sulfate beds mixed antibiotics in orthopedic surgery, what a pharmacist need to know. Dr. Shourouk, she will join us through virtual. Please welcome Dr. Shourouk. Because of the clinical issue, so we will move to the questions because Dr. Shourouk, she have a clinical issue. So now we have questions for Dr. Ahmad Taqi and Dr. Khalid. Please join us on the stage. Any questions for Dr. Ahmed and Dr. Khalid? Any questions? Can you please bring the mic there?
Assalamu alaikum.
Thank
you. Hello? Assalamu alaikum. Thank you, Dr. Khalid and Dr. Ahmed, for the nice presentations on informatics. I have a couple of questions. The first one, what about in regard of antimicrobial stewardship? If we think of from ASP point of view, just keeping the Linezolid for the more cases that have a resistance and just treat the patient with the first line options as a standard therapy. The second question in regard of the cost, which one is more cost effectiveness, the Vancomycin or Linezolid? The third question, if there's any real cases in your institution, you treated patients with Linezolid, either IV or oral? Thank you so much.
Okay, actually all questions are excellent. Thank you very much. Okay, so sorry, what was the first question?
First question about from
okay,
ISP.
yeah, the stewardship. Okay, yeah, very good point. And always in practice, as you know, we consider several factors, not just one factor. So if we just talk about stewardship and we want to keep Linezolid for VRE or specific cases, but let's look at the other advantages that we presented. You could argue that even with stewardship, considering stewardship, some might think, well, still I'm going to use Linezolid. Why? A lot of hospitals, they keep the patient in the hospital to continue the whole course. As you know, if you keep the patient in the hospital and on IV, on catheter, they will be at risk of resistance, including multi-drug resistant bacteria. So it's a balance, it's a risk-benefit. Keeping a patient in the hospital, using catheter have its risk. And yes, I agree, some have issues with Linezolid that you want to save it for selected cases. I think it's risk-benefit. I don't think we are saying use Linezolid for all patients, but at least we want to change the previous idea that I will never use Linezolid. It's static, or there is an FDA warning. This is our main goal from this debate. Does that answer your first question? So it's important, but it's risk-benefit, right? Okay. And the second question about
The cost.
the cost, Dr. Ahmed?
Yeah, also a second good question. So if you look at the cost of the drug itself, yes, Linezolid would be relatively more expensive than Vancomycin. But if you look at it collectively at the cost that Vancomycin can cost, you look at the staffing, you need drug monitoring, you need levels, you need pharmacists dedicated to do the calculation of Vancomycin. And then you also, if you calculate the length of hospital stay, Linezolid would facilitate discharge from hospital quickly. So if you add all these up, I think the cost effectiveness of Linezolid you can argue it will be more cost effective than Vancomycin. And then the third question, I don't remember. What was the third question again?
It's only 2 questions. 2 questions only.
2 questions. Thank you.
Could you please bring the mic to Nada? No, there is questions there. So we have just 2 more questions, Dr. Nada, and the last question from there.
Assalamu alaikum. Thank you so
Assalam.
much for this great presentations in this mind-changing discussion. So from the discussion today, I can see that Linezolid will become the new Vancomycin in the new era or future. So what do you think are the problems that may come with using or substituting Vancomycin with Linezolid in the future?
So these questions, who will answer? Dr. Khalid?
I mean, we can both answer. I don't think Linezolid would take Vancomycin, take the place of Vancomycin. Vancomycin is still our go-to and first-line treatment for most staff, and specifically MRSA infections. But what we try to say here is we shouldn't overlook Linezolid when we have staph bacteremia specifically. It has its role. It showed to be effective and safe for the treatment of staph bacteremia. So I don't think we want for Linezolid to overtake Vancomycin as the first line for MRSA infections.
So last questions, then we can conclude our sessions. This question for Dr. Khalid and Dr. Ahmed about the drug-drug interaction. So you know, when the pharmacy they're checking the Linezolid with SRI, they will found in category X, so should be contraindicated. Is it absolute contraindicated? Because sometimes we need to use Linezolid because the patient have allergic for Vancomycin or whatever. So is it absolute contraindicated to use Linezolid with the SRI agents?
Absolutely not. Actually, there's a good paper that came out about 2 years ago and looked at I think 1,800 patients who took Linezolid with serotonergic agents, and they only reported 2 incidents of serotonin syndrome, which tells you the rate is very low. But there are certain agents, as citalopram, islatolopram, and methadone that comes with a higher risk of serotonin syndrome in themselves. So maybe patients with these agents you want to be extra careful with, but I wouldn't say it's an absolute contraindication.
Yes, I totally agree with Dr. Ahmed. You know, sometimes the manufacturer, they have to put in the prescribing information, it's contraindicated, because it's a MAO inhibitor, simply, like the older antidepressants. But is Linezolid itself contraindicated? Well, it's a weak MAO inhibitor. As Dr. Ahmed said, some hospitals publish their experience. They are using Linezolid in a lot of patients who are on agents that increase serotonin, and the incidence of serotonin syndrome was too rare. So I would worry the most if someone is on, let's say, a strong serotonergic agent like SSRI, high dose, multiple serotonergic agents, I will worry the most in those patients. But you will find some agents, they increase some neurotransmitter, including serotonin, a little bit, and you will see a contraindication in the database. This is not actually an absolute contraindication. If you can avoid linezolid, use something, that's fine. But if you have to use it, it's not an absolute contraindication.
And just to add something, it's an additive risk. So if you have someone on more than 2 agents, maybe you want to be careful. But if only a single serotonerogenic agent, you can feel slightly more comfortable to use it.
Thank you, Dr. Khalid, Dr. Ahmed, for a very informative talk. So we can conclude our ID sessions. Thank you for all attendance.
Thank you.